We are on to traction. So, traction is the second of our manual therapies that we're covering in modalities class. Our third will be massage. And traction takes on some of the same kind of components that we talked about with joint mobs, as far as this is really about the joint surfaces and how they are in contact with each other. And using traction, or sometimes called distraction, to remove the pressure on those joint surfaces can have some benefits throughout both joints, but specifically in our case, we're going to be talking about the spine. So let's do a little background on spine pain, since you guys have not had Tech 3 yet, which talks about spinal conditions. We'll do a little bit of kind of information just so you have kind of an idea of how traction can really be used with different patients. So spinal pain most often comes because of degenerative changes in the spine. Okay, and this is when we're talking about chronic spinal pain, not something acute like a muscle spasm or a muscle strain. In this case, we're usually talking about where the bones surrounding of the vertebrae surrounding the disc, or the discs themselves, become weakened and damaged because of injury, aging, overuse, things like that. So as we age and as we put more stress on our spine, either through injury or improper posture or biomechanics, the intervertebral discs start to thin. And so remember, those intervertebral discs are really kind of like jelly donuts, right? You have the annulus fibrosus, which is that outer layer of the disc that's really thick and harder. And then you have the inside, the nucleus pulposa, which is like the jelly of the jelly donut. And so normally those are stacked up fairly nicely. They absorb water and are pretty good at absorbing the shocks in our spine and all of our body weight. Well, as we age, we lose water, and as we continue to load those discs, they start to thin out. And as they start to thin out, the annulus fibrosus can become weaker, and so that can cause some problems with the discs that we'll talk about in a second. The other thing that can happen as we overuse our spine is we can get these osteophyte formations, which are essentially like little outcrops of bone. Okay, so we get these little spikes and overgrowth of the bones around the vertebral discs, as well as in our facet joints. So the facet joints are where we have the superior and inferior articular facets within the spine itself, and they can get these osteophytes growing from and being laid down from improper balance in the joint surfaces. So we talked about that with joint mobs too, right? That if we have the wrong parts of the surfaces of the joints in contact and overabundance of pressure, the body is going to respond to that. Specific adaptations to impose demands. And one of the things that it will do will be lay down more bone. Well, if you lay down more of that bone, you actually inhibit the space for the nerves to come through, either the spinal cord itself or the spinal nerve roots as they come out of the spine. So lumbar pain, about 80% of the population will experience low back pain at some point in their life. 90% of it resolves in about 2 to 4 weeks. So most people rest, take it easy, do some stretching, and their back pain typically goes away. The issue with this is that 60 to 80% of that will recur within the year. And there's so many causes of back pain. There's a reason we dedicate almost a full class to spine evaluation, because there's so many reasons that someone can have back pain. We're going to just talk about a couple of them that traction would be beneficial for. But it's really important to do a really strong evaluation before you do any sort of treatment on a patient. So like I said, a lot of our focus is also going to be on those intervertebral discs, and I'll come back to talk about cervical pain in a second. But those intervertebral discs, again, are those jelly donuts where if they start to thin, or if they get kind of tweaked and squished in the wrong direction, maybe from an improper lift or move or twist, the damaged disc can become problematic and not give you the same support and the same movement that it was. So damaged discs, as you move into weight bearing, so normally the nucleus pulposa, that jelly part, acts as kind of a little axis of rotation. So as our vertebral column bends and moves, that jelly kind of shifts in the annulus fibrosus and allows us to kind of rock our vertebrae around in multiple directions. Well, when that becomes damaged and we go into weight bearing, the nucleus pulposa will start to shift due to those fluid dynamic principles. And if there's a tear or a weakening in the annulus fibrosus, in the donut part of the jelly donut, the jelly, the nucleus pulposa, will move towards that tear because it's the path of least resistance. And eventually, if that tear continues to get, you know, outer to the outer layers of the annulus fibrosa, that nucleus pulposa will turn into a bulge, and it will kind of push out on the outer rings of the annulus fibrosus, and that bulge can then impinge on the nerve root or on the spinal cord itself. That can cause a lot of pain. So we talked about lumbar pain a little bit already. Cervical pain, about 30% of 25 to 29-year-olds will experience some form of neck pain, cervical pain, and that increases to about 50% if you increase your age to 45 years or older. A lot of times in the cervical spine, if you have issues, especially with those bulging or herniated discs that we talked about, or some of these degenerative changes, the osteophytes and the thinning, so that then we have abnormal pressure on some of the bony structures. We tend to, when we have that thinning of the intervertebral disc, we put more pressure on those outer structures, the facet areas of the lumbar spine, or the spine in general, I should say. And that can, again, close off the areas that the spinal cord and the nerve roots especially have to move. And so bulging discs, herniated discs, degenerative changes, all that can cause a lot of referred pain into the arm. So where traction can kind of kick in is traction when we pull apart the vertebrae. We can actually decrease the central pressure in the disc space and encourage that nucleus pulposa, if it's bulging, to kind of move back towards the center. Also, that mechanical tension from the traction when we pull apart on the annulus fibrosus and on the ligaments that surround our spine, they can also help kind of push on the disc and kind of push that nucleus pulposa kind of back into the center. So this is just from your book, again, kind of showing that prolapse and that bulging. So a protrusion, the prolapse is getting into kind of more of the outer layers. The extrusion, we're out to the out through the outer layers of the disc, and then the sequestration, where we have much of it kind of coming out of the annulus fibrosus. So your discs, again, are these soft tissue. They're meant to be able to absorb water. And so actually when we are our tallest is when we first wake up in the morning, because they've absorbed water overnight, and so they're higher, they have more height to them on the vertebral body. So we're actually tallest in the morning. But during the day, the weight of the body kind of slowly compresses the discs and dehydrates them. And so that dehydration can also weaken the annulus fibrosus. And that happens more and more as we age too. We don't absorb as much water into our discs, and so they naturally kind of stay more flat versus when we're younger. So those protrusions or bulging can cause problems that then we can hopefully, through use of traction, help to separate the vertebrae and kind of pull that nucleus pulposa back and away from the spinal nerve roots and the spinal cord. Another condition that can cause a lot of our symptoms for spinal pain, especially those that radiate into the limbs, is stenosis. And so the intervertebral foramen, okay, is going to be that space between the vertebrae. And so this is looking at the side of the vertebrae here. So the spinal cord would be coming down here, and the nerve roots would be coming out where the red dots are. Well, if we get abnormal pressures, so if that intervertebral disc starts to shrink and the vertebrae sits lower, that's going to shorten the space and make the space smaller. If we have more pressure out here on the facet joints, so out on all the bony outcrops of the vertebrae, that's going to potentially pinch in. And then if we start to get that stenotic growth, so if we start to get those osteophytes growing into the space, we can kind of see that here, and we see some of that going on here as well, that's going to narrow that space and continue to narrow it. And so again, the disc degeneration, so you can see how much space we would have for the disc here, how little space we have here, and what that does to the nerve root as it comes out. And then again, decreased space plus these osteophytes kind of growing. That is stenosis, where we get that narrowing of an opening. Whenever we hear stenosis, that's what that means. So we get that narrowing of the intervertebral space and the area between the vertebral bodies, and that's going to put some pressure on those nerve roots and can produce some of those radicular radiating symptoms along the extremities. So changes in the weight-bearing load of the vertebral bodies and the facet joints and the biomechanical changes that result can cause those osteophytes to grow, like in figure C here. And that's going to increase the inflammation of the nerves and cause more pain. And then we have something permanent that has grown in that space. So then usually surgery potentially has to be happen to remove those osteophytes. Sometimes this then would also be that they'd remove the disc and put a bone spacer in here so that we increase the space, but then we lose movement in that joint, which can also cause more osteophyte and problems. So ideally we avoid spinal surgery when at all possible, and try many other things first, because it makes very permanent changes that then can cause greater problems at levels above and below where the fusion would potentially take place. So we can see by with traction, if we pull on these vertebrae and separate them, that even for a couple seconds, that gives a little bit of relief to that nerve root. And eventually, if we can do that enough, along with other treatments and other experiences, we can hopefully get that nerve root to not be as inflamed. So by the time we get to the osteophyte formation, there's not much we can do besides bring some temporary relief. If we're in the beginning stages where it's maybe because of disc degeneration or poor posture or some other biomechanical alignments, then hopefully we can make some difference with some traction, let that nerve decrease in inflammation, and then with exercise and posture training and different things like that, we can keep that space as open as possible. So what is traction? I've mentioned it a little bit already. Traction is a distractive force. We're basically kind of pulling apart. In this case, we're talking spine, but it could also be in the joint. We're pulling the joint surfaces apart. So cervical and lumbar tractions apply a longitudinal force that separates the vertebrae and opens up those intervertebral spaces in the area. It can be done with gravity. We'll talk a little bit about that. We can have a machine or do what we call mechanical traction. The clinician themselves can apply that force, or we can do positional by the way the patient lies down or in certain positions. That can actually relieve some of that pressure in the intervertebral space as well. That increased space reduces the pressure on the discs as well as on the nerve roots. It helps open up those facet joints and helps to elongate all the soft tissue along the spine, which has probably been shortened and guarding and in muscle spasm because of the pain elicited within the joints of the spine itself. The force can either be continuous, where it's just pulled apart and held, or it can be intermittent, where it's pulled apart and then a relaxation lets it go back together and we pull apart again. It just kind of depends on the goal of the treatment. It is not something that you do lightly. You need to make sure that you have a good diagnosis, that you know what the condition is so that you can use traction appropriately. It can be unipolar, where we just pull in one direction, or it can be polyaxial, where we maybe include some rotation or some other directions to kind of get a little different of a opening to the space based on the symptoms that they have. It's indicated for any mechanical pressure issues within the vertebral column, the facet joints, the spinal nerve roots that are being pinched, degenerative discs, whole list of things that we'll come back to, but basically anywhere pressure is causing most of the symptoms. So we use it for hypomobile vertebrae. So we talked about that with joint mobs, only hypomobile joints. So joints that aren't moving well. If someone has a hypermobile joint, so we have conditions in the spine that are usually due to potentially stress fractures or full-blown fractures called spondylolysis or spondylolisthesis, where the vertebrae actually move too much. We would not want to use traction for that, because that could cause those vertebrae to slip and put more pressure on the spinal cord. So any instabilities, any fractures, any joints that are hypermobile, we would not use traction on. Ideally, again, like all of our modalities, the goal is to use active exercise as much as possible. So if we can combine traction with active exercise, the traction can get some short-term mechanical relief. The active exercise, stretching, postural alignment work can actually hopefully make a difference in the actual alignment of the spine and open up those spaces more permanently. And so traction really just becomes about some short-term mechanical relief, because these conditions can be so painful, they're debilitating. It's not usually used for acute conditions unless explicitly prescribed by the physician. For the most part, these are chronic conditions that we see. The effect and effectiveness of traction is related to the position of the body, specifically the spine, the position of the patient, the force that we can apply, and the duration of the traction, along with the angle of pull. So how we pull it and how we position the body will change the effect that we have of the traction. So in order to actually distract the vertebrae, the force applied has to be sufficient to overcome all of the resistance of the weight of the body, the weight of the limbs, the contraction of the muscles, all of that resistance all summed together. We have to have enough force to separate and go beyond those resistance levels. So all of that, and even the force of friction, all of that has to be kind of overcome, gravity, whatever we might be doing in order to actually separate these vertebral bodies. So again, the types of traction that we can perform, the constant or continuous, is a constant tension applied for an extended period or extended time, potentially days, delivered using mechanical means, weights, pulleys. That's usually used when someone needs like a traction splint. More of what we do is what we call sustained or intermittent. So sustained is a constant tension for about less than 45 minutes, delivered usually mechanical means, motorized, just because that'd be a really long time to sit there and pull on someone manually. So it's almost always used mechanically. Intermittent allows bouts of tension with no tension. So maybe on for 15 to 120 seconds, and then there's a time with no tension. That can be mechanical, or that can be a manual technique that we'll do with our hands. Best for high traction loads, stretching soft tissue, separating the vertebrae. Sustained allows better separation of the bony structures, so the facet joints. So if that's more of the issue, then the sustained treatment is usually better. If it's more of a disc or soft tissue stretch, the intermittent can sometimes work better. So manual, again, sustained or intermittent, but more often intermittent, applied by the clinician. You can also do positional traction, which the traction in the spine is based on the patient's posture and uses gravity. So in this case, the arms hanging between the legs, it uses gravity to separate the thoracic and cervical vertebrae. A lumbar, okay, where we pull and use the arms to pull the lower extremity, that separates in the low lumbar when you kind of push your back into the table. That will open up spaces in the lumbar spine. So these are positional traction. And then auto traction is a mechanical traction, but the patient actually controls the amount of tension. So usually special type of tables and things like that. Other terms to think about, the angle of pull. So if you're in more of a neutral position, that's the transverse plane, the discs are going to elongate, and that nucleus pulposa has the time to pull in potentially. We're usually talking about, when we talk about the angle of pull, we're talking about the angle of the applied traction described relative to the long axis of the vertebral column. So if you go into more flexion or extension, we can target different areas of the spine as well. So the inferior facets of the cervical spine are angled a little more anteriorly, so they end up kind of angled forward like this. So then flexion increases the space of the intervertebral foramen as well as the facets more so than being neutral. In the lumbar, the inferior facets angle a little more posteriorly, so actually extension kind of increases that space. We can also do unilateral, so side-to-side tension. So if only one facet joint is shrunk, or if we only have single-sided pain, sometimes we can do some work just single-sided for the nerve root impingements or the muscle spasms. And then the multi or polyaxial, where we combine several motions. That's done more so on the individual vertebral level versus ours traction that we're going to talk about, kind of pulling the whole kind of vertebral column. So we don't do as much of that, but it's something you might see. And then the final kind of term to be aware is the amount of tension. So the amount of tension that's applied to the body is expressed in either pounds or the percentage of the person's body weight. There's no one formula to use. We want to use the least amount of resistance or tension, I should say, as we need to overcome the resistance of the body and to relieve the symptoms. So usually cervical, we talk about 20 to 25% of the, or 20 to 25 pounds of force. For the lumbar spine, we usually talk about 50% of the body weight that we have to apply to get the separation of the vertebrae. Less force is needed to distract the cervical spine than the lumbar because of all the muscles that surround the lumbar spine, because of the additional gravity, because of the additional weight of the body sitting through those vertebrae, we take more. And then the vertebrae that are closest to the source of traction are going to need less force to separate than those that are further away from where the traction is happening. So if we're doing cervical spine and we're pulling on the head, we're going to get to separate, C2, C3 much easier than C6 and C7.